All right, acute coronary syndrome. We'll flip through this rather quick. These are just different names people have for chest pain. They come up with the different names and different things that they do. Okay, so ACS, acute coronary syndrome. All right, cardiac compromise is another term that they might use. All right, but they just use these terms dealing with the cardiac-related type chest pain. When we get to respiratory emergencies and problems, then we'll talk about respiratory-related chest pain. You've already watched the blood vessel, right? Video. So we look at this, arteriosclerosis, or hardening of the arteries, all right? So about this artery right here, this was your artery maybe when you were 5 or 6, okay? I read some time ago that this process starts about age 2. Because what happens about age 2? Huh? You start eating. So you start eating more, you start eating non-liquid food, okay? So through the years, okay, these arteries start to harden, okay? Before we jump off into that boat now, keep in mind that this space here, see how round sort of this artery is and how open it is, all right? And the pressure, everything's about pressures, okay? So lower pressure, correct? Better blood flow, bigger hose. Think of it that way. You have a bigger hose here because it's not clogged up, all right? There's not a lot of pressure there. So good blood flow, not bad. As life progresses and you're introduced to McDonald's, okay, you get more of this, okay, and then smaller diameter, right, of the, and I'm trying to think like crazy, what, the lumen becomes smaller, okay, I knew there was a medical term for it, but the lumen becomes smaller, and the other problem is with this plaque, with this buildup here, it's not stretchable, okay? I don't know if you've noticed that when you picked up the heart and you looked inside the vessels and you saw the plaque, right? Did you guys see that? Did you take note to see it? It's inside those vessels in the heart, so it's there. So you all of a sudden now you get this, and it's not. There's no elasticity to it, all right? So now, not only is the vessel becoming higher in pressure, okay, but it's losing elasticity, all right? Arteries are supposed to be elastic. They have more elastin, right, than veins do. They're more stretchable, right? And then somewhere in between this one and this one, you're introduced to bluebell, okay? So you start binge eating bluebell for years and years. He's like, I'm just going to keep on doing it because it seems like the right thing to do, okay? And then all of a sudden now we get this clog here and then here, and now you can see high pressure, a lot of plaque buildup, all right? The 5th 6 weeks, we will take this and we will look at this part here. Not now, but this plaque buildup, okay, is a problem now, and it's going to be a problem then, but we'll learn more about this buildup and actually what takes place in more detail. Remember, this is just an overview, but a few months from now, we'll pick this up, and we'll look at this plaque buildup again. But we'll know this arteriosclerosis, this plaque buildup, and now we have this small lumen, all right, which would decrease its blood flow, increases pressure, decreases elasticity of the vessel. All right. We'll skip these now. I showed them last year now, and nobody understood it. They're hilarious, but nobody laughed because you didn't know what it was. But once we finish this, we'll come back. These are actually tutorials. And for people in medical school, they're little cartoons. Okay, everybody remembers a good cartoon, right? And so they use these for to explain acute coronary syndrome. But we'll wait till you understand it, and we'll come back to the this part. Watched it, right? Okay. So let's talk about that cardiac-related chest pain. So we're going to set a little bit of a scenario up for you. You have Steve over here. Steve is a 60-year-old male patient, okay? And he comes into your clinic, and Steve is complaining of chest pain. That's his chief complaint. And you go through your assessment, and he's also complaining of shortness of breath, nausea and vomiting, radiating pain. Radiating pain is pain that moves, right? So we'll look at this. So his chief complaint is chest pain. Cardiac-related chest pain is typically, not all the time, so we treat worst to least, right? So anybody having chest pain, and my paramedic professor told me that any pain, I remember it all these years, any pain above the belly button is cardiac related until proven otherwise. It's a very true statement, and it has saved my bacon many times, okay? Because of the fact that someone, especially females may only complain of nausea. Diabetics, they may only complain of nausea, right? That's pain above the belly button, correct? So we would take action to make sure that they're not having a heart attack. Right? That one statement has saved my job many times. Any pain above the belly button is cardiac related until proven otherwise. So Steve is complaining of chest pain. In cardiac related pain is usually a pressure type pain, okay, or a squeezing type pain, right? But there's something substernal, under the sternum, right? So substernal pressure type pain that is constant. It doesn't fluctuate with respiration. So otherwise the pain doesn't increase upon inspiration, right? That is more respiratory type pain. Typically, not all the time, very important, okay? Not all the time, but typically that is respiratory. It sort of gets you thinking there, but we're going to rule out the worst thing, which would be the heart attack, right? So he's having pressure type pain, squeezing pain. Sometimes the patients will even tell you, it feels like someone's sitting on me, okay? It's just pressure. Now, I've had patients in the past say, well, I don't have any pain. I don't have any pain. But this pressure in my chest is killing me. So pressure and pain are the same, okay? Do you see how that can get confused when you ask the patient, what, on a scale of 1 to 10, what is your pain? 10 being the very worst. Well, I don't have pain. Oh, okay. But this pressure or this squeezing, all right, those are all the same. It's abnormal in the chest wall, okay, to have. So it's a pressure type pain. It may radiate or move to the arms, the shoulders, both arms, left arm, shoulders, neck, back, okay, so it's radiating pain. Shortness of breath means that, they can't catch their breath. Having dyspnea, okay. Nausea, put vomiting. So let's back up here. So we have Steve here, 60-year-old male patient, complaining of chest pain. He describes the pain as a pressure type pain. Okay? Flag 1. Now the German Shepherd ears are up. He's got our attention. Okay? He says, man, I'm short of breath. I don't seem to be able to catch my breath. Okay? Flag 2, and all of a sudden now we're going, okay, I'm nauseated and I vomited twice on the way to the clinic. Boom. That dude is having a heart attack until proven otherwise. Okay? It's sort of like a scale. When you have a scale, show that justice scale right in the middle, right? And so you have an MI over here, okay, and it does the scale this way. So you have the MI here, and you start putting the signs and symptoms over here. Pressure type pain, substernal pressure type pain, nausea, vomiting, shortness of breath, boom, right? MI, until proven otherwise, okay? Very important. It is important to predict this in the sense that it could be life-threatening, okay? So we look at all these life-threatening things very seriously and quickly, all right? So, shortness of breath, nausea, diaphoresis, remember the medical term for sweating, diaphoresis, weakness, okay? Other things that we may look at with cardiac-related pain, because the OPQRST, right? We talked about that, correct? Okay. So provocation, the P. Provocation. What makes it worse or better? So this cardiac-related pain, So you ask this patient, what makes this pain worse or better? Does exertion make it worse? Okay. And they go, yes. Yes, I can't get up to go to the toilet without it hurting. I can't move. So this scale here now is really looking towards that, okay? Pain upon exertion is usually cardiac-related pain. As we get through the OPQRST, right? Time, describe it on the quality of pain, right? Sharp. Is it sharp pain? Is it dull pain? Is it tearing pain? Oh, pressure pain. Is this a pressure type pain? I'm going to give you guys a list of questions and stuff to get you going. So over here you won't have, you'll have sort of the questions that ask until you memorize them. But do you have all these different things taking place? Do you have these signs and symptoms? And then we're going to rule it out. We're going to make sure that this guy's not having a heart attack, and that's still to come. Okay? But let's talk about the two different types of pain first that they could have. Angina pectoris is chest pain. Angina pain, pectoris, right, chest. All right, so chest pain. It occurs when, like it says here, when the need for oxygen is not met. So the cardiac tissue needs oxygen, but it's not being met. The demand is not being met. Okay, so the patient starts to have chest pain. Heart muscle doesn't get enough oxygen-rich blood. So we have to figure out why is that. There's two different types that you are familiar with, right? What type did you watch the long video over? Huh? Unstable and stable. Good. So you have these two different types of angina pectoris or chest pain, okay? They differ in the sense from someone having an MI or myocardial infarction, okay? Because the angina will go away. Angina type pain goes away. The person having the MI, the pain doesn't go away necessarily, okay? Until you give them enough drugs to do that. All right? So, angina pectoris, one, let's talk about the stable. So let's look at Steve. We're going down our sample history, this 60-year-old male having chest pain, okay? And we get down to pertinent past medical history, all right? And he goes, yeah, I've had a heart attack in the past before. Okay, so he already has a heart condition. So back in the past where Steve has had this heart attack before, he was prescribed nitroglycerin. The medicine's a vasodilator, we'll learn about in a few minutes, that dilates the vessel. And Steve's doctor, his cardiologist, said, okay, now that you have a cardiac related history, once you start working or exerting yourself, you may get chest pain. Okay? You may get that pressure in your chest. So if you do, what I want you to do is to stop, rest, okay, and take a nitro. Take a nitroglycerin pill. Alright? That is considered stable angina or stable chest pain. Or the word that I look at best is predictable. It's very predictable. So let's say that Steve goes out and he goes, well, I've had my heart attack, but I still have to cut the grass. You know, can't get Granny to cut the grass for me. So I still have to go out and mow. So Steve is out there mowing the grass. He's exerting himself in North Texas in August. And he's pushing, he's mowing the grass, All of a sudden he starts having this substernal chest pain. Okay? He gets a little short of breath. Right? You know, the light clicks on saying, oh yeah, the doctor told me to rest. So he cuts off the lawnmower. He goes in the house. He sits down. He rests a little bit. It's still not really going away. Maybe decreasing a little bit, but not going away. And he goes, oh yeah, the doctor told me to take this little white pill, this nitroglycerin. So he takes the nitroglycerin sublingual, or under his tongue, and he sits there, and all of a sudden, boom, pain goes away. Okay? So no more chest pain. It's stable. It's predictable, right? It's predictable when Steve exerted himself, all right, that he may get this type of chest pain that he had when he had his MI, okay? What's the difference? Pain goes away. Very good. Pain went away. It's very predictable. So Steve remembers now the cardiologist is saying, once that pain goes away and you have zero pain, then you can get up and start doing what you were doing. So Steve goes back out and he cuts the grass again. He starts cutting grass. He finishes up, right? He goes in, he showers up, and he gets that half gallon of homemade vanilla Bluebell, and he starts eating again. He says, I don't care what that doctor said, I'm still going to eat this half gallon of ice cream. I deserved it. I cut the grass. Right? So stable, right? Stable angina. It's very predictable, and it's lifelong. It's not going to go away for this cardiac patient, okay? But he doesn't need necessarily to call 911 or go to the hospital because he's listening to his doctor and he's taking his nitro and he's resting, right? It's very stable, and it's going to continue the rest of his life. So that's sort of what he does. He probably needs to change his diet a little bit, okay? Put down that half gallon, go to a pint, maybe, right? Split that pint in half. You know, maybe exercise a little bit more, right? Do things to maintain a little bit better health. All right? Now, so stable, you guys watch that, supply and demand. Now we look at the other one, unstable, and it has an initials to it. USA, unstable angina. So now Steve is sitting there watching, you know, super high stress golf match, right? He's all in it. He's going, yeah, I'm into this, right? He's getting excited about the golf match, but he's resting. He's at rest, okay? Or even worse, he's asleep. Okay? So now Steve's asleep, or he's at rest, and all of a sudden now he starts having the chest pain. Right? He goes, well, hey, my doctor told me that I'd have that when I was being exerted, but I'm resting now. I'm watching golf. I mean, what kind of physical activity is that, right? So now you're resting and you start having the chest pain. Or you get woke up at night having the chest pain. So it's unpredictable, right? Because it's not happening the way that the cardiologist lined it out. It's becoming unpredictable. Reversible and progressive is the sort of the way. I got these from the American Heart Association. So unstable may be associated with an MI. Maybe. But it's unstable. It means that things are taking place that are not very predictable. So what Steve should do now is, if he can't get this pain to go away with this nitro, if it's reoccurring, then he needs to go to the hospital. He could be having an MI. Okay? What most people do is they'll say, oh, I'm going to call my cardiologist, okay? And the cardiologist will schedule them for appointment and different things. But guess what happens?
He died.
He didn't make it to his doctor's appointment. I can't tell you how many times I've seen that patient. We get there and someone's doing compressions on them, and they look up and say, some of them said, we were going to the cardiologist today, or we have an appointment next week, right? And so my suggestion is unstable angina, USA, you need to go to the hospital to make sure that you're not having an MI. If it's reoccurring and it doesn't go away, right? My suggestion is by ambulance, because again, you get into the ER, you think about it, ask those nurses how many times they have had to drag a patient cardiac arrest out of the front seat of a car because they drove them to the hospital, right? Treatment begins in an ambulance when they get there, right? Sometimes even before the engine comes and they start treatment, correct? Okay, you can't do anything in the front seat of your Buick, right? So does everybody sort of get stable, unstable, predictable, unpredictable? USA is a medical emergency. We don't want to mess around with the chest pain because they could be having the big one. Right? They could be having the MI. Now, most people will wait and see if, hey, can I get this to go away? Right? Can I get this pain to go away? But it would definitely, with unstable angina, that person should be more cautious about that.
Can a stable angina ever go into an unstable angina?
Oh yeah, definitely. Yeah, it can work into, the patient can have stable angina for years and years, and all of a sudden just start having unstable angina. Good question, yeah.
What can cause that?
Just the clot, the progression of the clot here. You know, this is getting bigger and bigger and bigger. Hey, you didn't stop eating that half gallon of Bluebell, right? So this thing keeps getting bigger and bigger, and all of a sudden now you have a full occlusion. Occlusion is to block off, right? To occlude. So this clot now is fully occluded here, which will cause the MI. There's no blood flow getting through, no oxygen getting through, okay? And that's where we are now. The acute in medicine means, within about 4 hours. So acute myocardial infarction. Infarction is dead tissue. So you have cerebral infarction, which would be a stroke, right? We just call it a stroke because those words are too long to say. It's easier to say stroke, right? It's easier to say heart attack or MI. But myocardial infarction. So the difference here is you look now, just like we talked about, the clot is completely blocks the coronary artery, this coronary artery, right? There's no blood flow. There's no blood flow getting down to this tissue, this distal tissue, distal away, right? Distal tissue, there's a block right here. So there's no blood flow getting down to this area. Now what this causes is dead tissue. I mean, this is dead tissue. Within about 60 minutes of this, the tissue is going to die, all right? And dead tissue doesn't come back, right? This won't come back. So what's going to happen here you have the surface area of the heart. You take the heart. Let me get my heart. I'm going to pull it out over here. I'm going to grow some of you out. And I don't want anybody fainting. I just had to. Okay, so you have the heart. You can have an MI on any surface of the heart, any surface of the myocardium, right? And then an MI can occur. Remember, the heart gets its blood through what? The coronary arteries, right? During diastole, it gets its blood flow. So it can have an infarction on any surface of the heart. Posterior, anterior, what's this? Inferior, lateral, right? Any surface of the heart, an MI can occur. Right? Left side or right side. Probably more on the left. Why?
Because that's where more of the work happens.
Very good. That's where the workload is. 75% of the workload of the heart is on the left side. Okay, the left ventricle. That's why it's thicker. When you picked up your heart, did you see how thick that left ventricle is? Mm-hmm. Okay, compared to the right. So you have any surface of the heart here. So what this does is, if you have an MI, if the patient has an MI like this is called surface area. It encompassed a large surface area of the heart. So it took out a lot of area of that heart. So now that area doesn't contract correctly. I have to say it slowly. A wall abnormality. Abnormal, right? Wall abnormality. So you have, let me draw. So you have the heart here, and you have this big surface area now that is infarcted. It's dead tissue. It's been a couple hours. They thought it was gas. It wasn't gas. It was an MI, right? And nobody in their household knew the difference. You get the picture? You know the difference, right? So here, now this part of the heart doesn't contract. There's no contractility. So it's, instead of going, because it contracts from the bottom to the top, and let me see if I can get my hands working. So it goes like this, right? Ba-boom, ba-boom, ba-boom. Now you have a wall abnormality. I don't really say it. I wish they'd come up with a different word, but you know what I'm saying? So you have this. You don't have this anymore. You have this. Right? So this is not contracting. What is that causing? Very good. Decrease in cardiac output.
So then the other one will try to compensate. The right side will try to compensate for it.
Well, not really. But so cardiac output, CO, cardiac output, 4 to 6 liters per minute. That's a big L, okay? We determine cardiac output cardiac output is determined by stroke volume times heart rate. Right? So the cardiac output in short means oxygen supply, right? We're pumping out adequate amounts of blood to deliver adequate amounts of oxygen. Everybody good with that? So we have cardiac output, 4 to 6 liters per minute. Stroke volume is an average of 70 milliliters in an adult, always, for now. 70 milliliters. The definition of stroke volume is the amount of blood ejected from the ventricles with contraction. Okay? So when the ventricles contract, the right and left, but we mainly look at the left, okay? Let's focus on one side at a time. So the left ventricle, every time the left ventricle contracts, to have proper average amount of stroke volume, okay, it should eject 70 milliliters, okay? Everybody good?
Mm-hmm.
We'll talk about ejection fraction a little bit later. This is milliliters, so what is this? What's that a measurement of? Huh? Volume. I was wondering if that was the right way to say that, but since you said volume, I guess right. So this is volume. That's not a V. Hang on. Volume. That's an X. I'm so glad it's Friday. Volume. Okay, this is volume. Ejection fraction. A fraction is what?
Something.
EF, ejection fraction, is a percent. Okay? So an ejection fraction is a percent. So our normal, for right now, we're going to say normal ejection fraction is 55%. I think it's like 45 to 55. Is it?
It's milliliters over minutes, right?
Oh, what? Oh, okay. Ooh. That's good. Okay, so 55%. Let's just, you raised 45 then. Let's go with 55. Ejection fraction. That's the percent of blood ejected from the ventricles. See how they're sort of close? We'll go with more ejection fraction when we talk about congestive heart failure, okay? But ejection fraction, 55%. So you have stroke volume at 70 milliliters, and then you have the normal heart rate is what? 60 to 100. So you take...
6 milliliters over minutes, right?
That's a zero, come on. Okay. So we have 60 to 100. So you take, to get cardiac output, because decreasing cardiac output can cause altered mental status, hypoxia, blah, 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 anything connected with oxygen, right? Decreased cardiac output. So if for some reason we had decreased the stroke volume, that's going to affect the cardiac output, correct? Mathematically, and I know I'm on thin ice here talking about math, but mathematically, it's going to increase. It's going to affect cardiac output, heart rate. Too slow or too fast is going to affect cardiac output. Why is that? I can't hear you over there if you're saying something.
They can have a decrease of blood flow to the vessels.
I had it in my head, like a decrease in heart rate, like not all the blood's getting out, so it's like a lower cardiac output.
And then your blood pressure tries to.
No, let me just tell you, okay? You may be thinking it, but you're probably overthinking it. Too fast heart rate, too slow heart rate decreases refilling time. Okay? Boom, right? Love, dove, boom. In between the heartbeats, in between systole and diastole, there's a period of time there, right? Remember, it's measured in time. Boom is a time. Love, dove, right? Doesn't happen. So you have, and you will understand this a lot better once we get more into the physiology of it later. But there's a period of time. Diastole, it's at rest, right? And diastole has a certain period of time that it's at rest. What is it doing when it's at rest? Refilling. So if it's going blah 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 blah, right? It's going like this. There's no time. The diastole time is shortened, so the refilling time is shortened. That makes sense, right? Mm-hmm. Okay. If it's too slow, the same result. It's refilling okay, right? What is it not doing? Right, it's not pumping it out fast enough. Okay. So stroke volume, heart rate, cardiac output. Cardiac output is hugely important as we move forward. Okay. But now we have this big clot here. All right. So we have to fix this. This patient's having an acute MI, and we have to fix that clot. When you go to the cath lab, cardiac catheterization lab in the hospital, this is what you're going to see. Okay? This person's having this chest pain. He may be having a what's called a Stemi, that we'll get to in a minute, but a Stemi, and this means that they're having an acute MI. They're having a heart attack right now, so they have to go to the cath lab to break this clot up, to remove this clot. Okay, so this tissue doesn't die. Everything is on a period of time, but you'll see that. Okay. There we go. The blue bell starting to sort of add up here, add up, and all of a sudden, boom. Too much. The clot, sudden death. So once that clot sort of forms up, remember the guy that gives our presentation? He was saying that clot took place, that widowmaker. Okay. This widowmaker, this clot is high. See, I mean, you see this coronary artery, and it's going way down here, okay? This is high on this left ascending coronary artery, or left descending coronary artery, okay? And if it's up here, where that is, that person's going to go into sudden cardiac arrest, okay? If it's down here, they're probably going to sudden cardiac arrest because of the surface area of the MI. Because they're not getting blood flow down to this area here. So they have to go in and they have to open that up and reperfuse, right? Perfusion, adequate perfusion, is the ability to deliver oxygen and nutrients to the tissue or cells, right? This would be inadequate perfusion because it's not delivering oxygen to the cells. So we look at this, and now we got the blockage. So the patient could go into sudden cardiac arrest. So we look at this chain: discomfort, pain, pressure, squeezing type pain, heaviness, palpitation. What's a palpitation? Well, to palpate is to touch. Palpitation, we're talking about the heart. No, palpitation is, if I drink a Monster, I start having palpitations. My heart will go. Okay? It's like tonight, because the game's so far away. Homecoming, right? Homecoming game.
This is the homecoming game?
No, next week. No, not next week.
You're right next to the person that you expended all that energy asking out to homecoming, right? And you're ready, and you're just like, man, I hope she says yes, or no, right? And then your heart goes, palpitations. You feel your heart beating.
Is that good or bad?
That's bad, okay?
No, but like if it happens regularly.
Especially with an old man, it's bad, okay? But you shouldn't have palpitations in your chest. Okay, so it fits the word, right? Palpate, you can feel in your chest, you can feel your heart beating, okay? Or fluttering, right? Radiation down one arm, right? Dyspnea, like we talked about, nausea, vomiting, impending doom, feeling impending doom. Patients can feel, they have a sense there where they know something's not going right, and all of a sudden, man, I feel like I'm going to die. They feel that. All right? So these are definitely signs and symptoms of potentially a heart attack. Vomiting, diaphoresis, nausea, a tachycardia or bradycardia, pressures, blood pressures, and another day, we'll talk about cardiogenic shock. Okay, so you have these different pressures. All right, so you have these signs and symptoms, and what we do is we take these signs and symptoms and we add them up, and if they add up enough, which in this case is not very many, we're going to rule out that that patient's having an MI. Okay, so we go through a nice good assessment using our acronym SAMPLE and our OPQRST. Right? We do a good assessment. We take vital signs. We trend those vital signs. We get a good baseline set of vitals, a good SpO2, room area SpO2. We see if there's a need for oxygen or not. Not everybody, even if they're having a heart attack, not everybody gets oxygen. To receive oxygen, according to the American Heart Association, okay, their SpO2 has to be lower than 94%. Okay? All right? Their SpO2 has to be lower than 94% or having some sort of respiratory compromise. Dyspnea, or work of breathing. They have to have an increased work of breathing or dyspnea or a SpO2 below 94%. If they don't have this, then they don't get oxygen. We'll talk more during the physiology portion months from now about this, but having excess oxygen creates these free radical ions that have been proven to be more damaging to the heart. So this person having a heart attack, they're having, if you don't used to, we just gave everybody oxygen. Thinking it's not going to hurt anybody. Now from 2010, okay, they're saying don't do this, don't give this oxygen. Withhold this oxygen if they don't need it. But change comes slow in medicine, okay? You still see it in the hospitals today. But according to the American Heart Association, which sets the guidelines for cardiac care, okay, below 94% dyspnea, work of breathing, increased work of breathing. Right? Then we give oxygen. Otherwise, we're creating that environment for these free radical ions that we'll talk about later. It's sort of, it is interesting a bit, but you go, after we talk about it, you go, okay. And then move on, right? So they need to either have this clot buster, which they don't really do a lot anymore because the current care is the cath lab. They need to go to the cardiac cath lab, all right, and have that clot removed. What they'll do, they'll place a stent in there and open that vessel up and remove that clot. Or they may balloon it if it's worse. If it's really, really bad and they have multiple blockages, then they'll have to do what's called a cabbage. Coronary artery bypass graft. What they'll do is they'll take a vessel, usually from the thigh or something, okay, and they're grafted on to the heart. If they have multiple grafts, then they'll have or jumps, right? They bypass it around the blockage, okay? This is open heart surgery. So coronary artery bypass graft, so they'll take that vessel and just bypass that leakage or that blockage, right? And go around it. And how many times they have to do the jumps depends on how many grafts that they have to put as well. But you'll definitely see that in the cath lab. I'll get to my pictures here just a second. Close your eyes so you don't have a seizure. Okay, so here we go. Here's what you see. This is the screen that you will see in the cath lab. Okay, this person's having this widowmaker. See, there's no blood flow. There's supposed to be an artery right here, a big coronary artery, right? The huge coronary artery right here. The LAD, left ascending. I'm having an old moment, but I'll have to look it up. I've lost it. But this big coronary artery right here descends down this way. Left anterior descending coronary artery. Coronary artery, or the widowmaker. Why is it called a widowmaker?
Kills men.
And women.
And women.
It's a killer. People that usually have a clot here, if they're not in the light, they're walking towards the light. Okay, they're dying. Okay, and it's really cool. You know, it's not cool they're having a heart attack, but it's cool that we're there. It's really cool to see that. This person here, people get really excited. Cardiologists and doctors, everybody gets really excited when they say, oh, they've got this. They see this. They go, oh, we don't have very long to open that up. Okay, I mean, we really are talking life and death here. Unresolved death, for sure, if not sudden death. Okay. Now look at it. See the distal flow? They open this up. Give you a comparison. Occluded, blocked off, right? Open. See the nice distal blood flow? Right through there. So now that would be life, death. Okay? So anybody want to do cardiology? Yeah. You'll be there. You know? Now this person lives unresolved. This person's without a doubt is going to die. Medically. Okay? So they open him up, they reperfused. Now he's getting adequate blood and oxygen and tissue, or oxygen and nutrients to the cell, right? He's perfusing.
Oh, for that, would they still have 20 to 60 minutes to like resolve it, or would they just die quicker since it's more up on them?
Here,
Yeah.
they could die instantly. Okay? They wouldn't know until autopsy time or whatever. But this person here, they started having that pressure type pain, and you know, I'm speculating a little bit here, but this is a real patient. I took these at the off of all the hospital. Okay, so there's no identifier. So this person was having that pressure type pain, nausea, vomiting, diaphoretic, throwing up, 10 over 10, right? Called an ambulance, went to the hospital. They recognized that this patient was having an acute MI, and then sort of off to the cath lab. We'll get in. We don't have time to do it today, but we'll get into the Stemi. This patient here was having a Stemi, and they reperfused, opened it up, and life again. Okay? So you have different, here's the graph that we're talking about. Okay? They'll go in and maybe balloon this. See the picture of the sort of the balloon? Alright? And then there's the picture of the stent that they go in. The stents can collapse. Alright? This little stent, you probably won't get close enough to it, but thousands of dollars. Okay? That little piece of mesh.
Does it keep the plaque from like constricting the?
Yeah, it opens it up. It opens it up. Yeah.
Is the MI the same when they go into cardiac?
No, cardiac arrest is patients dead. They could go into cardiac arrest from the MI. Yeah. Cardiac arrest is there's no heartbeat. They don't have pulse. So you see the sort of the difference here, the different things that they will do, depends on the patient. This would be the graph that we just talked about. Alright. Most time they're going to put this stent there, a little mesh. So our treatment, okay, now we get into a treatment phase. This is your treatment phase for your scope of care for the classroom, okay. In your assessment, they call it MONA. You just have to mess the words up a little bit, but you don't do it in that order, okay? I don't know what it would be in the order, but anyway, we'll make up a new acronym. But MONA, morphine, oxygen, nitro, and aspirin, right? So the treatment, we claim it as MONA, but let's start at the top. Oxygen. So if the patient is in need of oxygen, he's less than 94%, he has dyspnea or increased work of breathing, we supply oxygen. Nasal cannula, non-rebreather, it just depends upon the dyspnea, the work of breathing, right? Okay? So we provide the patient with oxygen. This is the abbreviation for aspirin. We give the patient aspirin, 325 milligrams of aspirin. Aspirin has a lot of different uses, okay? Any thoughts here why we give the patient aspirin? No? Not the pain. The chest pain is coming from the lack of oxygen. The muscle, right? So it's different, this doesn't help. Yeah, different pain. Aspirin, probably not in the video, so I'll just tell you, okay? You give the aspirin for the anticoagulant properties of the aspirin, or to say it easier, aspirin thins the blood. It's sort of like a blood thinner. All right. They just changed this recently. I read it on Harvard Medical News. Thank you, Twitter. That years ago they recommended anybody over the age of 40 start taking baby aspirin because they predicted this arteriosclerosis, right? Huh? Just as a supplement, you know. They said that years ago. I tried it when I turned 40. It gave me a headache because it thinned my blood down too much. It gave me a headache. I stopped. Okay. Now they're saying that that's really not. You really shouldn't do that unless you've been prescribed to do that by a doctor. Okay. But anyway, aspirin will thin the blood. That's why we give the aspirin. Why do we need to thin it?
So it can move on to another clot.
Sort of. What? No. What's the blood trying to get around?
It's trying to get around
the
the
occlusion,
plaque, so
or the blockage,
thinning.
right? Very good. The occlusion or the blockage. So it thins it down so it can get through. Remember the big vessel, right? Right? Now it's this big because of all the plaque buildup. So it thins the blood down so it can get through there. Okay? It helps with thinning the blood. It's delivering oxygen, right? Nitroglycerin, or nitro, the class of drug for nitroglycerin, the class of drug is a vasodilator. So nitroglycerin is considered a vasodilator. It dilates every vessel in the body. Okay? So if it's going to dilate every vessel, including the coronary arteries, right? So now we sort of thin the blood down. Now we dilated that vessel to increase blood flow, correct? It's going to increase blood flow. It's bigger. But since we've dilated that vessel, what happens to the blood pressure?
It goes down.
Right, it decreases. The blood pressure is going to decrease. So with that thought, what do you need to do before you give nitro?
reduce aspirin, like not give them as much aspirin?
What do you need to do? Think about it. Stay on the same track. If we're talking about blood pressure, right? So before you give,
Oh, you want to give them a blood supply?
somebody said it over here.
A blood supplement?
Check the blood pressure, right? Because it's related to blood pressure. If we give this vasodilator, okay, and because we gave that vasodilator, it's going to drop the blood pressure. We should probably know what the blood pressure is, right?
Mm-hmm.
So before you give nitroglycerin, you have to check the blood pressure. It's a must. You have indications and contraindications, okay? For medicines, indication would be why you're giving it, like aspirin. What's the indication? That's the action, but it's cardiac-related pain. So you give, the indication is you give the aspirin to thin the blood, which would be the action, but the indication would be cardiac-related chest pain. All right? Nitroglycerin, the indication would be cardiac-related chest pain, would be the indication. A contra, which would be against the indication, or something that you can't do. If it's contraindicated, you can't do it. Okay? It's a systolic blood pressure below 100. Now, you're going to see different numbers here. Okay? This is just a sort of a range. I think the package actually says 80, but we're going to use 100. So you can't give, it's contraindicated to give nitroglycerin below systolic blood pressure below 100. Why is that? Why is that a contraindication?
Because it'll make it drop even more.
Make your pressure drop even more, okay? So we know, because of we know how the medicine works. We'll know a lot more later, but we know that it's a vasodilator. I give it, it's going to dilate the vessels, it's going to drop the pressure. We don't really want the patient's pressure below 100 systolic. All of a sudden now their pressure's too low. You start getting dizziness and altered mental status and everything else, right? Nitroglycerin will dilate the vessels in your head as well. So what is it going to give you? If you dilate the vessels in your head, what do you get? Huh? A headache. All the time. When your vessels dilate in your head due to stress or whatever, you get a headache. Same way with nitroglycerin. One of the side effects of the medication is it's going to give the patient a headache. It's just a side effect. It's not a big deal. Who's humming?
Sorry.
Okay. So it's going to give the patient a headache. So nitroglycerin, vasodilator. So vasodilate, right? It's going to give the patient a headache. It's going to drop the blood pressure. So these are things that we have to be aware of. The other contraindicator for nitroglycerin is you can't give that medication to a patient that takes the little blue pill or Viagra, the erectile dysfunction medications that are out there. By the way, women have them now, called the little pink pill. Okay. So any kind of erectile dysfunction drug that they may take, you will pick that up because what do you ask them in your sample?
Have you taken
Medication, right? And they say, oh yeah, I take that Viagra, or what's the other one? Come on, you know, what is it? you know the other one. Don't be shy. Cialis, I think it is. Anyway, they have different kinds. So 24 to 48 hours after that, what takes place here? If they take that medication, you give them nitro or a nitrate, right? just a different form of the word, because it comes in different forms. It comes in a paste, it comes in a pill, it comes in an IV form, drip form. Okay, if they take a nitrate, then and they take Viagra, they can't take a nitrate 24 to 48 hours. What it will do is it may cause irreversible hypotension. So it'll drop the blood pressure, okay? And that's bad. It could cause, it's called a rebound hypotension, and they can't get the blood pressure up. Beta blockers, and we'll have to do get a little bit more into this later. But a beta response, when you hear beta, it's this B like here, the B with the little tail on it, okay? You have a beta 1 response, and you have a beta 2 response, and then you have an alpha response. There's a little thing for the alpha, but I can't remember what it is. Okay. So a beta 1, we have one heart. This is how I remember it. H. Heart. Beta 1, heart. So a beta 1 medication affects the heart in some form. Okay. A beta 2, 2 lungs. Affects the respiratory. A beta 2 medication affects the respiratory. It causes bronchodilation. A beta 2 medication causes bronchodilation. Beta 1 medication causes an increase in heart rate. Right? In alpha, causes vasoconstriction. So a beta blocker, what happens is on the cell, you have a cell here, okay? And on every cell, there's like a gazillion receptors. We'll speak more receptor sites later, but different receptors, okay? And if I gave a positive beta 1 like epinephrine, okay, and this is a cardiac cell. So if I gave epinephrine, that epinephrine would swim through the bloodstream and sort of look for this receptor site. And when it found it, it would go there, right? Go into the receptor site and cause a beta response. Everybody with me? Mm-hmm. Okay. If that happened, then it would increase the heart rate. All right? Everybody good with that so far? All right. What a beta blocker does here is it blocks this, it puts a chemical sort of door over that receptor site, so this beta property can't combine with this receptor and cause an increase in heart rate, right? So it blocks all the beta responses. So if the beta 1 response is to increase the heart rate, what would a beta blocker do? Huh? Decrease the heart rate. So beta blockers decrease the heart rate. Why would we want to decrease the heart rate in someone having an MI? There is an increased workload, yes, because it's not pumping correctly. So keep going, you're right. So what does the beta blocker do?
Oh, wouldn't it keep it?
Huh?
Uh-huh.
You're close. You're real close.
So would the energy stay like the heart, so it doesn't waste to any other part of the body?
You're close. Let me just give you the right term, okay? It decreases the workload of the heart. So you guys were right. Is that what you said? I just didn't hear you. See, you should have spoke up.
You heard me. You just ignored me. Okay.
Usually when I ignore you, well, there's several reasons why I would ignore you, but most of the time I just don't hear you. So, beta blockers decrease the workload of the heart. All right. Nitroglycerin decreases the workload of the heart. Okay. Oxygen will provide oxygen to the heart. All right. Hopefully, will decrease some of that workload. Now, morphine. Everybody good up to this point? Just general descriptions and everything? Give me more morphine, right? Morphine, the class of drug for morphine is an analgesic. It's a pain medicine, right? But like you said, it's a different, it's not necessarily pain. Like if I hit someone with this golf club, okay, that would cause pain. If I went over there and whacked Steve in the leg and hit him in the leg and it really hurt, maybe even fractured his leg, right? And they might give him morphine for the pain. That's painful, right? Where's the pain coming from? And I'll give you a hint. In the heart muscle or the myocardium. Why is there pain there?
Oh, because there's lactic acid created, the byproduct, because the muscles are overworking.
Very good. Up till you said overworking. But very good, that's right. It's creating lactic acid because of it's shifted into anaerobic metabolism because of the lack of oxygen, right? I think that's where you were going with it. Yeah. It's shifted into anaerobic metabolism, okay? So there's a lack of oxygen there, all right? And I've given you this example before with muscles, okay? If I took somebody that wasn't athletic, who's not athletic? So you didn't have to admit that, I mean, but if you went and I said, okay, I want you to run up and down these stairs as fast as you can, 50 times, okay? And all of a sudden now, as you're running up the stairs, you have the need for oxygen. Your muscles have the need for oxygen. They're going to start hurting, correct? The muscles are going to start hurting. They're hurting because of the need for oxygen. Make sense? Muscle in the thigh, muscle in the heart. Different muscle, but same principle, correct? So what morphine does is morphine, hang on, I'm buffering, hold a moment. Morphine will decrease the workload of the heart by increasing venous return. How do you spell venous?
N-O-U-S.
Venous return. Okay? And so it's going to increase venous return. The easy way to say it for today is it's going to increase the amount of blood flow that's returning back to the heart. Venous blood back to the heart. Okay? You may term it loosely, very loosely, as it's going to increase preload. And that's for another day. We've done enough for a Friday. Right? But it's going to increase preload or venous return. So oxygen supplies the demand of oxygen that's not being met. Aspirin will thin the blood down so it can get around the blockage. Okay? Nitroglycerin is going to dilate that vessel to help get blood flow to that area that's blocked off. Okay? The beta blockers are going to slow the heart rate down to decrease the workload of the heart. Now, what's the contraindication for a beta blocker?
When your heart rate is already low?
Right. Their heart rate is already low. They have a number, which is about 70. So they can't take a beta blocker if their heart rate's lower than 70, right? If we give them, they're bradycardic already, and we give them a beta blocker, we don't really slow their heart rate down, which is going to do what?
Kill them.
Yeah, but what term am I looking for? It's going to
There's a
decrease.
decrease in cardiac output.
Very good. Very good. It's going to decrease cardiac output. Then you're going to get all those other things that you guys just said, including death. Okay? So we have to be careful there. See, now we're having to think about these medications, right? And we'll have to analyze the patient. We're going, can this patient take this medication or not? Morphine decreases the workload of the heart. Always. We need to decrease it so it doesn't have to work so hard, right? And decrease venous, increase venous return. Everybody good? Yeah. Okay. Let me see where we're at. Because we are out of time. Close your eyes so you don't.
Yeah, next is Stemi.
Okay.
So we are stopping basically where you said we stopped.
So we'll pick up next time with Stemi. Okay.